Hi everyone, thank you so much for joining us. So a rather grey morning here in Leeds. Hope it's nicer where you all are. I hope someone's joined from a beach somewhere. That would be great. So welcome to 6B webinars. I am Sarah. I'm the Client Director of Healthcare. I'm joined today by Tom, our Technical Director, who'll be leading today's webinar, and Rebecca, our Commercial Director. So today we're chatting about unlocking NHS primary care data for digital health products. To start, I'm really sorry I've got some boring housekeeping. So if possible, could everyone apart from Tom stay muted? We've got quite a lot of people on the board, obviously that might cause some disruption. Just admit these people. If you do have any questions, just because of the number of people we've got on, if you could drop them in the chat, Rebecca's going to moderate that, and we're going to have a session sort of midway through to answer some and potentially at the end. Also, just to say, we will be sending the slides through after the presentation, so you don't need to take notes. We'll send them over. And if you do have a specific project on your use case or a specific project, we can get in touch after the call and arrange sort of a one-to-one meeting. And finally, if you do have any ideas on other webinars that you would like 6B to put on, we're going to do a suite of webinars every month. So we're always looking for new ideas. So please send them through as well in the chat. Be greatly received. So just want to give a little bit of background on 6B. So 6B is a technology and an engineering consultancy. We specialise in product development, healthcare integration and interoperability. So for the past 5 years, we've partnered with NHS organisations, digital health innovators, and we deliver user-centred digital solutions in this sector. We are, one of our core capabilities is interoperability. So we've got a lot of experience integrating some of the big EPR systems, both in primary and secondary care. So I'll just admit this person as well. Bear with me. And we also specialise at HL via pathways and NHS assurance. We've got a lot of experience with DTEC and DSPT, things like that. We're also involved in groups with NHS England and national projects like FireCore. So that's probably enough about us. I'm just going to pass over Tom, who's going to start the webinar now.
Awesome, Sarah, and again, thank you to everyone for joining today. So my name's Tom, Technical Director at 6B. I'm a hands-on developer and work across both consultancy and build, namely in healthcare and primary care, secondary care, a bit of tertiary care as well. So over the last 10 years or so, we've worked with all different private and public sector clients to achieve interoperability. So hopefully you're as passionate about me about healthcare interoperability. Don't worry if not, but over the next 30 minutes or so, I'm going to try and paint a picture really about patient data, how that can be worked in the primary care landscape, what data you can access, what's available to you, where is it stored ultimately. Then just to look at some specific use cases that may or may not pertain to you, to get the ball rolling there, and then to dive into the primary care integrations themselves. So what is there available out there to integrate in primary care? Like Sarah said, we'll have a brief pause and for any questions, and also at the end. And if there's anything as well you want to ask, we'll moderate that in the chat, but we can follow up separately as well after this. We'll then look at process and onboarding, maybe what API should you use, some questions to ask yourself, and then look at gearing up for any integrations you want to do or are doing, and then the governance and compliance side as well. So I'm going to try and cover a lot in 30 minutes. And some of the terms that we'll use today, quite a few acronyms in healthcare as we've found. So just wanted to label some things out here just so we're all aware of what I'll be talking about. APIs, we'll be talking a lot about them. A lot of you may know them, but they're just a set of protocols enabling systems to communicate and transfer data. FHIR, provided by HL7 body, is just essentially a way of sending messages between systems. We'll talk a lot about FHIR APIs and how they're enabled. EHRs, you're probably aware of, but in the context of this, it's the electronic health record, talking about System 1, EMIS, a little bit about Medicus as well, the new player. And then finally, HSCN, an acronym, which is essentially a VPN or a data network to access some of this information and may be required. So with that being said, looking at the primary care landscape, it's made up of now three EHRs and three players. There's two main players you're probably aware of in the market, which is Optum, who last year purchased EMIS and their product EMIS Web, and more recently EMIS X. EMIS, the last couple of months, have around about 58% share of the market, around 3,500 practices. So they are the more dominant EHR in the market, with System 1 provided by TPP, around about 42% of the market, so just over 2,500 practices they cover in England. And then finally, Medicus, the new player on the block, who are just about under 10 practices, but they are starting to become ION1 enabled and API enabled as they are entering the market. So the APIs and what we're going to cover today will namely cover NHS England. A lot of the APIs and assurances only cover England and the practices and patients within that. So it's just worth noting, obviously, that will soon be dissolved into the Department of Health and Social Care. There's no plans at the moment for any of this to change. It's just to be dissolved within that setting. But there's also NHS Wales, NHS Scotland, and then the Health and Social Care for Northern Ireland. Like I said, all of which are not entirely covered by these APIs. Some have overlap that we'll briefly touch upon. So looking at what data you can access, it's namely around a patient. There are some organisation and staff data that you can obtain through various APIs, but we're going to focus really on patients today and accessing the various different data through the APIs available. So we've got demographics, NHS number, we've got contact details, address. You can access allergies, immunisations, medications, observations and results. A popular one is documents, both pushing and pulling documents. And then we've also got GP appointments and referrals across the different settings as well. So that's not just primary care, that's pushing across the different care settings as well from there. There's a lot more data within that as well, and you can obtain, and other APIs and modules are available for more niche data, but this is certainly the most widely used data sets for a patient. And then finally, like I said, you can also obtain organisation and staff data through a lot of the APIs. So where is that data stored? So for a single patient and for yourself, likely your data will be stored across hundreds and sometimes thousands of systems in England, and then beyond that, even more. We think about that in primary care, secondary care. There's hundreds of systems involved at those levels. So your parts of your record could be dispersed across all those different systems. So in primary care, the patient record held in either System 1, EMIS, or now Medicus tends to be, and is the idea behind that, is a single source of truth for your patient record. So whenever you wanted to obtain a patient record, you would likely go via the primary care integration routes to obtain it through one of those EHR providers, and it is and remains to be the most comprehensive record of a patient. There are other available APIs in secondary care that will provide other information relative to any hospital visits or relative to a trust, but specifically patient data, primary care integrations remain the best route for that. So as part of that, you'll work directly or indirectly with the EHR providers, so in the System 1 and Medicus. And a patient's GP controls whether they can have direct access to their data via online services for numerous reasons, namely safeguarding reasons that patient's data might not be available. So once you interface, you still might not be able to access all patient's record for safeguarding reasons. Finally, of all that, the NHS England and the NHS governs this, but they have little control really over how data is stored and managed, and they're doing a lot of work and provide a lot of APIs to access the data, but it still remains in the HR providers' data stores. So having a look at a couple of example use cases, just to get us thinking about why you might want to integrate, or if any of this is relevant to yourself. So we've put a couple of examples here. Firstly, you might have a patient app that manages diabetes, where the patient can submit their daily glucose readings. and therefore you want to push those readings back to the patient's GP record, but also pull any historical results so that they can track progress over time. So there we've got a push and pull element to the GP record to EMIS System 1 or Medicus. We've then got a clinician-facing app. They might want to monitor patients' hypertension or anything else. And again, a patient can record their blood pressure readings, or we can obtain them through other sources. But then we want to review those in a clinician-facing app. We want to record any of the findings and notes, and then ultimately push that back to the GP record again. But at the same time, pull any medications and any relevant results so that a GP or clinician can make any relevant and informed decision around that review. So again, we've got a push-pull aspect there, but they are two different routes. Those two different use cases will take two different API routes, two different routes to obtaining and pushing that data back to the GP record. And it's just worth noting with any use case you may have, or when you're looking at this with primary care, that it's always got to be based around providing direct patient care. That's quite a broad thing. You know, it might it can sort of quite a broad area, but it's always got to be providing the patient, patient care. It can't be for any marketing reasons or whatnot. The reasons to obtaining their data. So with all that being said, there's a number of different APIs and routes available to integrating with primary care. What we've done here is we selected a handful of APIs, and again, you may have seen some online. You may think they're relevant to you in your use case. After further digging, there may be some questions you have, and again, we're happy to take those away or answer them today on this call. But the most popular ones, certainly that we work with, and when it comes to primary care, are these ones. And first of all, it's IM1. So IM1 is not a set of APIs, it's a process, it's a set of standards, and it's a team ultimately put in place by NHS England to manage the process of directly integrating with EMIS System 1 or in time Medicus. So IM1's been around for a long time and does remain to be one of the best routes to push and pull information. There are lots of other conversations around that, and there's no plans currently to discontinue IM1. IM1 has the ability to both push and pull to a patient's record for both a clinician and a patient-facing app. And IM1 also provides a bulk data option, which is not available via any other routes currently, nor when I speak to any of the other APIs or teams, it's not something in anyone's roadmap to provide data in bulk. So that still remains one of the most useful ways to obtain bulk data through that route. A couple of limitations with IM1. Firstly, you may require a local desktop application to be installed through a couple of the APIs, and you also have to work directly for the clinician-facing routes with the practice to have a local data sharing agreement in place. Looking at GP Connect, so GP Connect is one of the new APIs provided by NHS England themselves. When I spoke to them a couple of years ago now, that was the idea behind this, was maybe a long-term replacement of IM1. And that is very similar to IM1 in that you can pull back a lot of the patient record. Not a full comprehensive record like IM1, but it is pretty extensive now in what you can pull back for a patient. That's all file-based, so as I said before, so that's in a standardized format that that'll return. Unlike IM1, it varies per EMIS System 1 and Medicus provider, so that is in a standardized format. And GP Connect, interestingly, out of, I guess, one of the benefits of COVID is that they entered into a national data sharing agreement with every practice. So when you interface and work with GP Connect, that'll open you up to all records back for every patient in England on a national data sharing agreement. So it can be really, really useful if you don't want to, or you don't work directly with practices. GP connects, so you can pull most of the data, but it has very limited push capabilities, and at the moment it's only a document via their push document route. They do have some update record, but they're just not ready. They're very, very niche use cases for what they're allowed to do, and you may see that with GP Connect, that once you get down the line, that the use case is very niche and what it's assured and signed off to the use. And it's also only for clinician-facing applications and not patient-facing. that have patient-facing APIs online, but none of them are available. As of yet, they're not assured to do those, and I've been chasing them for a number of years, and it doesn't seem like they're on any roadmap anytime soon. Next, we get into a few more specific APIs. Personal Demographic Service, or PDS, you may have seen or heard of. Often used as a prerequisite for a lot of other APIs. So, for example, if you do GP Connect, you'll likely need to do PDS as well, because PDS is used to obtain and verify a patient's NHS number. So again, that's FHIR-based, and you can pull back their contact details, address, where they're registered to, their local pharmacy. It's a really useful tool to pull back patient demographics. So quite a lightweight process to get onboarded on. So yeah, it's very widely used and is the single source of truth, or seen as the single source of truth for patient demographics. The summary care record, not quite opened up fully yet, but the idea behind that is it's going to be a FHIR-based API to obtain a summary of the patient's record, including medical record of that patient and demographics. It's currently pull only, and I guess some limitations there are that it requires quite a few other prerequisites. So when you're doing NHS API integrations, you'll need to likely interface with other APIs, unlike IM1, which is just a direct IM1 integration. Next, we've got something slightly different, which is the e-referral service. Again, you may have come across that if you receive or send referrals to or from primary care. So that's a FHIR-based API, again, to receive and push referrals from primary care to secondary care and vice versa. Again, it requires the prerequisites, but it remains a primary way to send referrals around. Finally, we've got NHS login in there. So NHS login is slightly different from the ones above. Again, you may have come across this if you've got a patient-facing application. The NHS login is really widely used for patient authentication and authorization. So if you've got a login for patients, then NHS login is seen as the best standard to use there. It uses PDS and a few other APIs under the hood. And it also provides you back information, and it's almost a necessity if you're doing IM1 patient-facing services as well, because it provides you keys to then go on and integrate with the patient-facing service API. I've spoken to the team over the last couple of months. There's around about 42 million patients currently registered with NHS login. Of those, 75% are of P9, so their highest level of verification. So it's a very widely used and accepted patient authentication and login method. So it's something we definitely recommend if you've got a patient-facing app and are looking to embed integrations as part of that. So from there, we're going to have a quick pause for any questions that people may have.
Yeah, there's a few questions in the chat, Tom. So the first question, just to make everybody aware, we were asked if the slides will be sent around after the call, and they will. Then we've had a couple of questions on IM1. So firstly, are the details of how to integrate published anywhere?
Yeah, there is. Yeah, and we can provide some information on that. I've got a little bit later on onboarding, but it's all. We'll attach the link to the various different APIs we've put there. But IM1, yes, you'd go to their, and like every API, you would go to their API page. There's a lot of information there, and it's usually structured the same, but they have a section for onboarding. I'll come on to onboarding shortly, how it's different per provider, but for IM1, you'll submit a prerequisite form. In there, you'll ask what you want to interface with, so with EMIS System 1, and then a quick brief use case. So, why do you want to do that? They then all turn that around. It can be a number of weeks. The IM1 team will then come back to you on that, and they might ask some questions and might ask for some further supporting evidence on your use case, because at that moment they're just assessing your use case. Once they're happy, then they'll enter into the kind of queue and the IM1 process.
Lovely. And then in regards of the data that you're getting back from IM1 from the patient record, is that data in a standardized format?
So no, it's in a format that will come back the same every time. It's in a structured format, but it's not standardized across IM1. And that's one of the biggest problems we see from an integration perspective is it can be quite a tricky technical integration, but a lot of the time is around the governance, the clinical safety side, that's the SCAL process, but then it's the parsing of the data. And certainly if you're going to be doing a full medical record, that's quite extensive, and especially if you're doing the bulk data extract as well, because you're getting everything out in the bulk, or potentially everything out in the bulk. They then have different coding per provider. So for example, EMIS and System 1 are CTV3 native, they're not SNOMED native. However, they do allow SNOMED codes to be pushed back in via their API. But a lot of the data you will get out will be different. They'll be completely different per provider. And then they'll be completely different then within each module. So for example, medication, you might get a title name, you then might get a dosage and any supporting notes with that, and that is then maybe different, slightly different in System 1. So a large part is the mapping exercise between, if you're doing both or one of them, between your system and then the data that comes out of there.
And then one final question for now. In terms of accessing the summary care record, are there ways to do that without an NHS staff card needed to log in and authenticate?
No, not at the moment. No, so it is a requirement to have SIS2 as part of that integration. I think personally SIS2 will become more and more common for clinician-facing apps, as NHS login is becoming more and more common for patient-facing apps. So now at the moment, and as we're finding, the summary care record probably isn't available to everybody in its full guise at the moment, but it's likely if you are doing a clinician-facing app that SIS2, which is the authentication for clinicians via smart card and other routes, is likely to crop up at some point of your integration journey. It's not yet a full requirement. It is for summary care record. It's not for IM1. It's not for GP Connect, but in time it is likely. So I think if you are seeing it, SIS2 is not a particularly massive undertaking nor SCAL process compared to maybe the others. And once you have that in place, it is really, like I said, it does really help in terms of the data you'll get back. It's a big tick box in terms of your authentication for your product as well. Yeah.
That's all the questions for now. Thanks, Tom. If anybody's got any more questions as we go through, if you drop them in the comments, we'll try and address them at the end.
So looking at next, the process and the onboarding. Like I said, I think from my perspective, so we've currently got about 10 IM1 products in the queue at the moment, and it's very frequent that we're in that process. And from our perspective, that process for an individual API can change a lot during the life cycle of your process, but it's also worth saying that the processes in the onboarding are completely different per provider, and that's because you're just working with different teams, and you may be required. So therefore, as we were saying, their summary care record, you need to integrate with lots of other APIs and integrations, and none of those will talk with one another, nor will they be part of an internal roadmap. So that's something that you'll need to go through and ensure that you're lining up correctly on your side, so that you have SIS2, so that you can be onboarded to summary care record, for example. So knowing the onboarding, knowing the processes throughout is quite key. That's where we see a lot of the delays. For IM1, it's quite a long process at the moment. So anything you can do to pre-prepare, anything you can do to make sure that you're submitting the documents that you need at the right time, or just speed you up through that process. And that's what we're saying as well, that the documents that you'll create for, if you're doing a PDS integration, an IM1 integration, and a GP Connect, for argument's sake, the documents that you need to provide are namely the same throughout. That's your architecture, the DPIA, so you can reuse a lot of the work that you're doing as part of the onboarding and the SCAL process across the other areas, but still be some nuances per integration. So from an onboarding perspective, like I said, check out that section. We'll send around the link and a specific a link to each onboarding section for each integration. It's usually submitting your interest by an online form. Recently, they've onboarded ServiceNow So there's a ServiceNow portal where you'll need to either create an account if you don't have one, which you'll need an ODS code for, which you can create one if you don't have. And then you submit an interest for that API. They may ask for some supporting information, but usually your use case is a couple of paragraphs around about why you want to use it, what you're going to be doing with the data, and ultimately what's your product or services. And again, that's always got to be phrased around direct patient care and how you're going to be obviously using that data to enhance the patient experience or patient care, either through a clinician activity or a direct patient activity. So once you've found that onboarding, you submitted that interest via form or on ServiceNow, so there'll maybe be a back and forth. You'll then likely enter into a SCAL process. The term SCAL is not always used throughout them, but it's the most common, and that's a supplier conformance assessments list. And that can come in different guises again, always completely different. GP Connect and for IM1, they are documents, they are Excel spreadsheets with lots of different tabs to fill out at lots of different stages. So again, just be aware, it is noted of what you need to fill out at what stage. That covers technical side, it's your architecture side, it's your resiliency and things around hosting. And it's your clinical safety, it's your product information as well on there. So it requires quite a lot of different fields to fill in different areas at once. So usually, if we're doing, it's quite common, we would do a SCAL or manage the SCAL on behalf of the client, even if we weren't doing the development. And we'd likely run workshops with the different internal stakeholders, clinical safety, technical, and then the product teams to make sure that we've got input from all of the right people in the different sections. But then, like I said, you can usually copy and paste those through the different scouts if you are doing those. If you're doing a lot of the NHS England APIs, it's likely that you'll then be onboarded and undertake your SCAL through the digital onboarding service, which is an online website, an online portal. Again, you can create a free account where you can actually sign up and register your interest for some of these APIs, but then you'll submit your information through online forms in different sections again. So it's a nicer process because you have automated emails back on any feedback received, and you can see the status of your submission online. On there as well, you can create credentials for each environment. Today, you could go away, create an account, and you could also create credentials, API keys to get started on PDS, NHS Login, and a few other different APIs straight away without any sign-off required. But moving to the later environments, you would need sign-off required for that. So looking at all that, the technical side, what's available, what questions you need to ask, and what the onboarding looks like. What API should I use as a product, as a service, whether that's public or private sector? There's a few things to think about that we always flag very early on in the process. So a few things to think about is integrations are not one size fits all. You may need to interface with a number or multiple APIs to achieve your desired goal, either through prerequisites or just an API might not fully fit the exact information that you need. An example of that might be that you're fully interfaced with IM1, but you just want some more information or really up-to-date relevant information on someone's nominated pharmacy, for example. So PDS remains a really good option to get that information really quickly via their cloud-based RESTful API. So again, it's just working with the different integrations for your needs. As I said, they're prerequisites to really understand that, have you covered off all the integrations you need there? But also don't take that as a barrier to entry as well. NHS Login, SIS2, their teams are really, really good, like all of the teams are, but certainly NHS Login, their team's really proactive and working with you as our SIS2. So the process, they make it really easy to be onboarded and work with them so that you can ultimately use their products to authenticate either a clinician or a patient as part of a prerequisite and for another API. know your routes. It's quite common that we speak to people and they'll see an API and they might not know it's available to them, and that's usually down to two routes. So there's the patient facing, as I've said, and the clinician facing, and that's quite key. You understand which of those you fall down, and the truth is you might fall down both as well. There might be a grey area, but the way, certainly if you would interface with GP Connect or IM1, if you have a patient facing app or you want to show patient facing data back to a patient, there are different routes you need to take, the clinical safety routes, but also technically. So for example, in the IM1, you'd go down their patient facing services APIs, the clinicians would be their transactional or partner APIs. And that's a difference in authorization and authentication, but then what's available. So patient facing routes, you can't push a lot of data back. You can push and book an appointment, but you can't push a problem or medication, unlike clinician-facing applications where you can do a lot more available to you. We always recommend think iteratively, so doing all of this or a lot of integrations in one big hit can be costly and can take a lot of time. Yourself or even your clients that you work with can lose interest because of the time it takes. So you always try and say, if you can try and think iteratively. So can we go live with NHS login, then can we later introduce PDS, a certain other functionality, then bring in IM1 for pull and push on there. But with that being said, because of some of the delays around IM1, GP Connect, and how long it takes to get as part of that, we'd always recommend that you try and include for certain APIs 18 months to 2 years worth of your roadmap as part of that. So an example might be if you're looking to just do bulk today, but in future you might want to push a document back through IM1, maybe in the next 6 to 12 months. Because of the time it takes to interface through IM1, we'd recommend put that down as part of your SCAL. By the time you get around to your witness testing and actually submitting it, you may have got around to that development where you might be able to prioritize certain elements to show that you can do that. And then you might not go fully live with that, but at least you're assured to do that. If you want to make changes or additions to your use case or technically, you need to go through the request for change process, and it's just exactly the same process as the start of applying for IM1. So again, it can take a long time to go for that change. So we always just recommend try and think what's on your next 12-month roadmap. Can we pull any of that forward, or at least get the development somewhat done so that we can get that assured? Thinking all of that, how else can we gear up for integration? So a couple of things we always recommend. Do you have a clinical safety officer? Now that doesn't need to be a full-time person in-house. It's usually a third party or outsourced person who is your named clinical safety officer. There's lots of different services out there that provide that, but that's required. That's required for all of the processes, all the integrations, and it's one of the key considerations as part of that. Is your product pen tested? So as part of all these integrations, DTAC as well, you'll need your product to be penetration tested. So that is an external third party who is CREST assured, has tested your product for any vulnerabilities, and you can provide a certificate back for that then. It needs to be the last 12 months that your product's been pen tested, so you may have already had it pen tested as part of another assurance or just as something you've done, so that's fine as long as it's within the last 12 months. You might require a HSCN connection, again something to think about because that can add on a little delay. It's also costs. The NHS does have a list of HSCN connection providers, and you'll work directly with them to integrate that as part of your hosting or product. Again, do you have your use case ready? Again, it's just a couple of paragraphs ready that you can submit that for any of the APIs. And do you meet the information governance and security standards that they require? So this DTAC, we'll come on to in a second, the SPT, DCB standards as well. You might not thought about if your product's a medical device. Again, it's not a problem if it is or if it's not. It's just being aware if it's a medical device, and your clinical safety officer again can review and help that. And something about as well, do you have pilot sites ready to test your integration? So you may have gone through a large integration, 12 months, it's a large product or an addition to your product. Do you have some pilot sites ready, some practices who might be EMIS and or System 1 just to test this? Because you'll have done testing in Sandbox, but it's not like the real world once you start putting real patient data and all the complexities of that. So do you have any pilot sites that go through that process? And they're really aware of that process and being a pilot site, so it's something they're quite common to doing. Also, just flagging data sharing agreements we've spoken about on here that you might need to enter into data sharing agreement per practice. That can be on a higher level, an ICB level as well. So just being aware of what data sharing agreements are required. And again, they're quite a simple form to fill out. It's not a large or extensive process at all. Finally, just wanted to touch on from subjects of governance and compliance. So all of this is going to be assured by an NHS England team, either directly, so IM1, GP Connect. You'll also be assured by the HR providers as well to make sure that you're being compliant with their data and patient data ultimately. And like I was saying, for me, there's a lot of these processes, 40% of it is development, the rest of it is assurance, it's governance, it's compliance, it's making sure that you set your products, but your company has got the right things in place to interface and integrate. So you must comply with the direct NHS and supply assurances, so that you'll do that as part of any GP Connect, IM1 or other API. And a lot of these are the same throughout as well. So like I said, it's a copy and paste. So once you've done it once, you'll have it across the board. But be aware of clinical safety standards. So DCB 0129, that's around development. Again, there's a lot of information on NHS England on that, and we're not going to go into that today, but also DCB 0160 as well, which is more around adoption and adopters as well. So just be aware of those standards, a lot of self-certification around that. DSPT, again, is a self-certification online. You'll need to just have standards met for this year. If you've not already done that, you can join online. Just Google DSPT. You can fill out that form. It usually takes around about half a day. There may be some other actions that you need to do off the back of that. But again, it's, you don't have to have done, and a lot of these things you don't have to have done absolutely everything. It's just that you're aware of it and you've got mitigations in place or a roadmap for some of these things, to be done. So they're just making you aware that you're aware of compliance and governance. So don't be scared off by a lot of this, and if you don't already have it in place or if it's not making sense. That's not the idea, but it's just making you aware and making sure that you have that on your roadmap at some point. Next is the new, or maybe not so new anymore, DTAC criteria. So that's some list of criteria that was given to ITBs and practices to help them assure digital products when they come on board. And think about it, everyone could do their own level of assurance. So the idea here is that everybody in the NHS is doing a standardised way of assessing digital products. Again, I've probably not seen this in practice actually enforced across the board, and not fully, but it's definitely something you'll need to be aware of, and it can just be dropped on you in procurement stage or when you're about to go live. So you definitely need to be aware of what it is, have it ready. And again, you don't need to have done absolutely everything and score 100 out of 100. Some of it might not pertain to you, but also some of it, you might not physically be able to do or just do at this time. So again, it's being aware of it. You've got mitigating factors for it, and it might be on your roadmap. So it's something we strongly recommend you have a look at. Finally, we've got the ISO 27001 certification that might be required, not always fully required, but usually brought as part of DSPT and DTAC. And then there's audit, login, role-based access control, consent management, the kind of words that will come up frequently via all of these integrations. So do you have audit login so you can see actions done in your system to a database somewhere, and then just role-based access control if you're not using SIS2 or NHS login. And that's the service as well as things like that. And it's probably things you're all already aware of if you're building products out there, but is it something we've got detailed down in a couple of paragraphs that we can submit that.
Thanks, Tom. We've just got a couple of minutes left, so we've probably just got time for one more question. I think David has put one in the chat. So I've spoken to individual trusts who want to access GP data. They don't understand why it's so difficult. They don't have the skills and time. I think we've seen this time and time again. Do you have an experience of a group of NHS organisations working together
Yeah.
to economies of scale, and how easy is it then to agree the data they need? And he's also mentioned obviously One London, who we know about, and the Universal Care Plan.
Yeah, and that's a really good question. It is really relevant at the moment. We do see that a lot, and we do a lot of work across and see a lot of work across an ICB level, a region level. That's very common. We're seeing a lot of consortiums coming about, mainly more at a trust level, because you're right, they are struggling to access their own data. But usually the access to them is the same, unfortunately, as it is for anybody else. It's going through trying to get that API key through the IM1 routes. For System 1 for EMIS, but you certainly could do that. You could, as a practice, as a trust, as a PCN, as an ICB, create a consortium to say, okay, we want to get data out for our regions. Just then enter into local data sharing agreements across that. That's more internal, and then it's going through the same standard integration routes. EMIS have a few more direct that you can speak with them. As do other providers that we won't get into today, like Cerner, Epic, and Summary Care Records. They are slightly different and more direct. But usually when it comes to System 1, they do tend to, regardless if you are an NHS Trust or whatever, they'll send you to IM1. They want them to cover off all of that assurance. It's just worth saying while we're on it, once you have an IM1 license and you're integrated with System 1 and EMIS, that does allow you then to integrate. The integrations are exactly the same for community care, where System 1 and EMIS is deployed, and EMIS and System 1 is also deployed in secondary care, or secondary care settings, and it's the same integrations. But they do want you to have an IM1 license because they know it covers off the technical, clinical safety side of it.
Yeah. Thanks, Tom. It's worth probably saying that we've got some fires in the irons that might help Dave with that question. So maybe worth having a chat after this and letting you know sort of what we're working on. But yeah, thank you so much, Tom. That was hopefully everyone found it interesting and useful. We'll send over the slides afterwards. And as I said, if anyone does want to have a chat about a specific use case or project, please do reach out. And we'll get a meeting in. Thank you very much for your time, and hope you all have a good rest of the day. Thank you.
Thanks, everyone. Thanks, guys.
Cheers. Bye,
Thanks,
guys.
bye.